Precedex, dexmedetomidine HCl, is an innovative IV sedative from Hospira. Precedex provides respiratory stability, comfortable and effective sedation, and a reduced need for morphine. Precedex is indicated for sedation of initially intubated and mechanically ventilated patients during treatment in an intensive care setting, not to exceed 24 hours. Precedex is different than other commonly used IV sedative agents. Precedex is an alpha-2 adrenoceptor agonist that exerts its effects via the alpha-2 adrenoceptor. This is a distinctly different mechanism of action than that of propofol or a benzodiazepine. Unlike many other sedatives used in the ICU, Precedex is not a controlled substance. This in-service video has been created to help explain what Precedex is, how it is different, and how to safely and effectively administer it to ICU patients needing safe and effective sedation. In animal studies, Precedex was found to work on the alpha-2 adrenoceptors that are located throughout the body, including the central nervous system, effector organs such as vascular smooth muscle, and especially in tissues innervated by the sympathetic nervous system. Precedex has been shown in clinical trials to produce sedation, inhibit sympathetic activity, decrease blood pressure and heart rate, and reduce the need for add-on morphine. Precedex is also able to maintain respiratory stability. The respiratory effects of Precedex after extubation in the intensive care unit were retrospectively examined in 33 post-surgical patients involved in a randomized placebo-controlled trial. There were no significant differences in respiratory rates, oxygen saturation, arterial pH, and arterial partial carbon dioxide tension between the Precedex and placebo-treated groups. As seen here, patients randomized to receive either Precedex or placebo maintained consistent oxygen saturation rates before, during, and after extubation. Precedex can be continuously used in patients prior to, during, and after extubation.
First and foremost, Versed or midazolam, whether it's pushed or whether it is in a drip form, has to be discontinued, allow the respiratory rate to rise, and then extubate the patient. And the same thing occurs with propofol. You need to discontinue it about 10 minutes before extubation, allow them to, their respirations to come up to their baseline, and then extubate them. Dexmedetomidine may give you the ability not to have to do that. You're able to extubate this patient while leaving them covered from a sedative perspective versus the other agents which you have to stop, and during probably one of the most anxiety-provoking experiences.
Adverse events indicating respiratory disorders were seen in 1% or less of Precedex-treated patients and were not statistically different than placebo-treated patients in Phase 2 and Phase 3 clinical trials. In Phase 3 clinical trials, Precedex was shown to reduce the need for morphine. Significantly fewer patients sedated with Precedex required add-on morphine for analgesia than control patients. In those patients who needed add-on morphine for pain control, the mean total dose was significantly less in patients sedated with Precedex versus control. This graph shows that significantly more patients treated with Precedex attained significant pain relief without additional morphine in Phase 3 clinical trials. In 2 trials, 44% and 41% of Precedex patients did not require add-on morphine, while this was true for only 19% and 15% of the placebo groups. Precedex also significantly reduced the average dosages of morphine needed to obtain adequate analgesia during the first 6.5 hours of study drug infusion. The data reflect the results of a prospective secondary analysis of 2 Phase 3 multi-center double-blind placebo-controlled studies designed to evaluate the efficacy and safety of Precedex in patients who required mechanical ventilation and sedation in an intensive care setting. Patients sedated with Precedex needed, on average, 4.5 milligrams of morphine, compared with placebo-controlled patients who needed significantly more morphine, 8.5 milligrams, in order to maintain adequate analgesia. The sedative profile of Precedex can differ from that of other IV sedative agents you may be more accustomed to using. Patients in the Phase 3 clinical trials reached clinically indicated levels of sedation and were adequately sedated, Ramsay sedation scores of 3 or more. However, when stimulated, some patients were reported as arousable and alert. Many patients sedated with Precedex may seem more arousable or alert when stimulated than with other sedatives you may be more accustomed to using. This is important for clinicians and caregivers to understand because the ability to be aroused should not be considered as evidence of lack of efficacy in the absence of other clinical signs and symptoms. When a patient is sedated with Precedex, the decision to administer additional analgesics or sedatives should not be based solely on the ability to arouse the patient. Adding unnecessary concomitant sedative agents and/or opioid analgesics may produce unwanted side effects. Before determining the need to administer additional analgesics or sedatives, question the patient to assess their true comfort level. This can be done by talking to the patient or by using a sedation or pain scale for an objective pain or comfort assessment if the patient is intubated.
So when I first used dexmedetomidine, it was a different type of sedation and not something that I was used to. We were used to titrating these sedative agents that sort of have a linear response. The more you give, the less responsive the patient is, and you can titrate it to some level of responsiveness usually, but oftentimes patients don't respond. And if they can respond, it's often that they're in a lighter plane of sedation than you want. We found something very different with dexmedetomidine when we first used it. These patients were patients who were well sedated by any criteria you would choose to use. They were calm, but when you spoke with them, they'd open their eyes instantaneously, like they were rousing from sleep almost, and follow commands, interact with you appropriately, and then when you stepped out of the room and left them alone, they'd fall back asleep again fairly quickly. So this was very different for us, and it took some getting used to. I think the nurses particularly were more used to having patients who were sedated and not responding. And they were concerned that these patients who were responding were not adequately sedated, where in fact they were well sedated.
Palmer. Hi. You have any pain? You have any issues at all? Is your chest okay? You want to write me a note? Can you write me a note? Oh, the breathing machine's fighting you? Okay. All right, we'll take care of that. Go back to sleep a second, and we'll be done in a little bit. Okay. One more. Otherwise, everything going great. Yeah, we feel the same way. Okay, can you just rest a little bit, close your eyes, and take a rest, okay? I'll get you off this machine, all right? Okay, just relax, close your eyes, take a nap.
The sedative profile of Precedex may seem different than that of many sedatives. This is particularly important in ICU patients, where balancing the need to extubate with appropriate sedatives and analgesics can be difficult. Precedex should be administered only by persons skilled in the management of patients in the intensive care setting. Prior to administration, Precedex must be diluted. To prepare the infusion, withdraw the entire 2 milliliter contents of the vial and add to 48 milliliters of sodium chloride injection to total 50 milliliters. Shake gently to mix well. Precedex has been shown to be compatible when administered with 5% dextrose in water, 0.9% sodium chloride in water, lactated Ringer's solution, as well as a number of other intravenous fluids and medications. Please see full prescribing information for a complete list. Precedex is incompatible when administered with amphotericin B and diazepam. Precedex is infused using a controlled infusion device. Dosing is individualized and titrated to the desired level of effect depending upon the patient's current state of sedation and concomitant sedative or analgesic use. Co-administration of Precedex with anesthetics, sedatives, hypnotics, and opioids is likely to lead to an enhancement of effects. and dosage reduction of Precedex or the concomitant anesthetic, sedative, hypnotic, or opioid may be required. Dosing of Precedex should be individualized and titrated to the desired level of sedation. Initiating Precedex therapy in patients already sedated with other sedatives or analgesic medications such as propofol, midazolam, lorazepam, fentanyl, or morphine is likely to lead to an enhancement of clinical effects and potential for side effects. Dosage reduction of these concomitant medications should be initiated when beginning a Precedex infusion. In patients already sedated with other agents, a loading infusion of Precedex may not be necessary, and a maintenance dose should be initiated and adjusted between 0.2 and 0.7 micrograms per kilogram per hour to achieve the desired level of sedation. Should a loading dose be used, it is generally initiated at 1 microgram per kilogram, administered over 10 minutes. Prior to initiating maintenance dosing, consideration should be given to the existing level of sedation and condition of the patient. In Phase 3 pivotal trials, maintenance infusion of Precedex was started at 0.4 micrograms per kilogram per hour, which is the midpoint of the titration range. As with other sedatives, dose reductions of concomitant sedative agents or opioid analgesics should be considered according to their respective dosing instructions and recommendations. Following a loading infusion of 1 microgram per kilogram given over 10 minutes to healthy volunteers, the sedative effects were observed in about 15 minutes. This is important to know so that pre-existing sedative agents or analgesics are not titrated downward too quickly before the sedative effects of Precedex have taken effect, or too slowly such that patients are oversedated. Patients can be evaluated 15 to 25 minutes after initiating Precedex therapy, or after each dosage adjustment to determine if adequate sedation, analgesia, and patient comfort have been maintained. In Phase 3 pivotal trials of Precedex, mean total dosages of rescue sedatives and/or morphine to achieve a Ramsay sedation score of at least 3 and adequate analgesia are shown. As you can see, a significant reduction in rescue dosages of propofol, midazolam, and morphine can be achieved when co-administered with Precedex. Overall, the most frequently observed treatment-emergent adverse events include hypotension, hypertension primarily during loading dose infusion, nausea, bradycardia, fever, vomiting, hypoxia, tachycardia, and anemia. Moderate decreases in blood pressure and heart rate should be expected when initiating Precedex therapy. In Phase 3 clinical trials, Precedex-treated patients experienced an average decrease in heart rate of up to 7% versus placebo-controlled patients. Additionally, Precedex-treated patients experienced an average decline in systolic and diastolic blood pressures of up to 10 to 11%. Reports of hypotension and bradycardia have been associated with Precedex infusion. Should medical intervention be required, treatment may include decreasing or stopping the Precedex infusion, increasing the rate of IV fluid administration, or elevating the lower extremities. Pressor agents can also be administered if considered appropriate. In clinical trials, atropine or glycopyrrolate were effective in the treatment of most episodes of Precedex-induced bradycardia. However, in some patients with significant cardiovascular dysfunction, more advanced resuscitative measures were required. Due to Precedex effects on heart rate and blood pressure, caution should be exercised when administering Precedex to patients with advanced heart block and/or patients with severe ventricular dysfunction. Hypotension and/or bradycardia may be more pronounced in hypovolemic patients, those with diabetes, chronic hypertension, and the elderly. Clinically significant episodes of bradycardia and sinus arrest have been associated with Precedex administration in young, healthy volunteers with high vagal tone, or when Precedex is administered differently than indicated, such as rapid intravenous or bolus administration. Transient hypertension has been observed primarily during the administration of loading doses. Treatment of the transient hypertension has generally not been necessary, although reduction of the loading infusion dose may be desirable. higher incidence of bradycardia and hypotension was observed following administration of Precedex in patients over 65 years of age, and dose reduction may be considered in patients over 65. Precedex pharmacokinetics, Cmax, Tmax, area under the curve, clearance, distribution, elimination half-life, and steady-state volume distribution were not significantly different in subjects with severe renal impairment, creatinine clearance less than 30 milliliters per minute versus healthy subjects. However, the pharmacokinetics of the metabolites of dexmedetomidine have not been evaluated in patients with impaired renal function. Since the majority of metabolites are excreted in the urine, it is possible that the metabolites may accumulate upon longer-term infusions in patients with impaired renal function. In subjects with varying degrees of hepatic impairment, Child-Pugh class A, B, or C, clearance rates for Precedex were lower than for healthy subjects. Precedex clearance decreases with severity of hepatic impairment. Dose reductions should be considered in patients with impaired hepatic function. Precedex is an innovative intensive care agent that provides comfortable, effective sedation, respiratory stability, and a reduced need for morphine. Precedex does not have to be discontinued prior to extubation. With these effects, Precedex can help extend patient comfort in the ICU before, during, and after extubation. Please refer to the package insert for full prescribing information. Please see your Hospira sales representative for more information.